Hi, I'm Finn.
Hi, I'm Ellen, and today we're going to talk about childhood apraxia speech. So, I'll present a bit of what it is, and then through a case and an intervention for it, and also do a role play.
The client's name is Amelia. She's 7 years and 1 month old. She's English speaking and she was diagnosed with child apraxia of speech. She had a typical pregnancy and birth. She had hit the early motor milestones with range. She had delayed speech onset, where her first words were at 2 years and 5 months old. Her parents and childcare staff have difficulty understanding her, and she does not show any hearing impairment or cognitive delay. So, when looking at Amelia's symptoms for CAS, she presents with inconsistent errors with words like banana, which are 3 syllables or 2 syllables. So, for example, she would say banana as nana, bada, or anana. She also has difficulty with syllable transitions, which are segmented or effortful productions. She has prosodic errors as well. So in the word banana, she would have equal stress banana instead of banana. She searches for the right oral movements for speech, but she can't always make them. And she has reduced intelligibility, especially to unfamiliar listeners. So the dynamic evaluation of motor speech skill found that she has poor accuracy of multi-syllabic words. She has difficulty imitating unfamiliar sound combinations. She has better performances with high frequency simple words, and she clearly has prosodic deficits as well. So, CAS is a neurological speech and sound disorder which impairs the precision and consistency of movements during speech due to difficulty planning and or programming the timing, direction, degree, force, and sequence of the muscles involved in speech sound production and prosody. Whilst one's reflexes and muscle tone are intact and their muscles are not weak, they have problems forming words in the right way. So, the causes of CAS, well, there's various ones, but there often isn't a clear cause. This is known as being idiopathic. However, other causes include from a neurological impairment, like a brain injury, a stroke, or an infection. It can be associated with neurological disorders like Down syndrome and autism, and roughly 1/3 of children with CAS are linked to having gene deficiencies. The symptoms can vary according to age and severity, but they include unclear vowel and consonant sounds, pauses between syllables or words, voicing errors such as the word pie instead of the word buy, trouble moving smoothly from one sound, syllable, or word to another, movements of jaws, lips, or tongue that are not the desired ones as they are searching for the correct movement for the speech sound, that's known as groping, using the wrong stress in a word or using equal emphasis in all syllables, saying the same word differently when using it more than once, and having a hard time imitating simple words. Whilst not symptoms, CAS can also result in less babbling than typical before 12 months of age, having their first words late, using a limited number of words and consonants, leaving out sounds when speaking, and having speech that's hard to understand. And the following can be presented with CAS but are not directly linked: delayed language, which may include trouble understanding speech, smaller vocabulary, not using correct grammar when combining words, delays in intellectual and motor development, trouble with reading, spelling, and writing, trouble with motor movement skills or coordination, and trouble using communication in social interactions. So, the prevalence of CAS is believed to be 1 to 2 children per 1,000. However, it is prevalent in other neurodevelopmental disorders like galactosemia, which is a metabolic disorder. CAS affects children because they have difficulty conveying meaning in everyday conversation, with issues regarding the distortion of speech sounds and dysprosody. Children can often be misunderstood because they can't produce a full range of sounds. CAS has also been linked to having a planning deficit because sentences can sound distorted. For example, a basic sentence like, Mum is going to take the dog for a walk, could sound like Mum taking is the dog for work. In a test conducted by Chernovsky in 2023, it was found that 95% of children with CAS experienced expressive language impairment, and 78% experienced cognitive impairment as well. Thus, children with CAS struggle with basic language tasks such as expressing their thoughts and ideas, and often have issues with memory and retention skills. Younger children with CAS have difficulties with feeding, cooing, and babbling, and when they do begin to talk, they only have access to a limited range of sounds. When they're around the age of 5 and onwards, these children find it easier to talk to themselves and are quite difficult to understand, even for their parents. Therefore, these children also experience negative social effects like making friends and isolation.
So now I'm going to talk about rapid syllable transition treatment, also known as REST, and it's been developed through research studies which have shown that REST can improve the speech accuracy of children with CAS. It aims to improve speech motor planning, normalize prosody, and speech production. And REST works on the sounds, the beats, and the smoothness all at the same time. And the aim is that the child produces all three components correctly. It's done by repeating the same stimuli several times to achieve accuracy and consistency in the production of the words. It is a motor treatment, so you give motor cues, and the principles of motor learning are used in designing the treatment, and the focus is on high intensity practice. And the REST treatment is designed to treat the speech motor planning disorder in CAS. In REST, children practice using their speech motor planning skills with unfamiliar words, also known as nonsense words, which requires them to make new motor plans instead of using existing ones. The client produces non-words that have been chosen specifically for the client and that are difficult but not impossible to produce. I'm going to talk about some scientific evidence on REST to prove that it actually works for these children with childhood hyperactive speech. So the first one is a randomized controlled trial from 2015, and that REST in that one showed improvement and maintenance up until 4 months after the treatment for both treated and untreated real words. And the study suggests that REST is efficient in treating childhood hyperactive speech in children between 4 and 12 years. And there were also strong generalization effects found to the real words. And it was 26 children with mild to severe childhood hyperactive speech, and 13 of them got REST and 13 got another treatment called NDP3. And it was 1 hour sessions 4 times a week for 3 weeks. The articulation and prosodic accuracy were assessed before treatment, at week 1, at month 1, and at 4 months post-treatment. And REST showed more effective treatment gains than the other treatment. Another study, a pilot randomized control from 2023, also showed REST to be efficient in the treatment of CAS. And was 14 children between the ages of 6 and 13, and they were randomly assigned to be treated with either REST or an ultrasound biofeedback approach. And they got 12 sessions over 6 weeks. The speech sound accuracy and prosodic severity in untreated words and sentences were evaluated before treatment, immediately post-treatment, and 1 month after finished treatment. The group that was treated with REST showed significant improvement on treated items and also in speech sound accuracy on untreated words and sentences from pre to post-treatment. But there was no improvement in prosody from pre to post-treatment. And then after, at the 1 month follow-up, the improvement was still present. And also the significant improvement in prosodic accuracy was reported at this 1 month follow-up. But in this one, the same results were obtained for the other treatment, so both showed to be efficient. And then a third study was a scoping review of McCabe's work, and it was conducted in 2022, and it focused on REST delivered via telehealth for children. Included only 5 children with CAS, and the intervention was delivered remotely through telehealth. But all children, also through this approach, showed significantly improved pseudo-word production after treatment. 80% showed higher accuracy for treated and untreated words, so there was generalization in this one as well. There was improvement in the untreated items, and rest via telehealth was, through this study, supported as a promising and effective intervention for CAS. But that we have to acknowledge that in this study, the sample sizes were small, so we can't draw that good conclusions through this. Talk a little bit about how a session can look in the rest treatment. So the session is divided into two parts. We've got the teaching or training phase and then the practice phase. In teaching or training, we teach the skills and competence so that the client understands what to do in the practice phase. And the child learns what to do through imitation. We can use different cues, prompts, and feedback, any strategies that would work for the client. And we focus on teaching the three key components: sounds, beats, and smoothness, both separately and in combination. Usually the practice phase is longer in the first few sessions and then goes on to be shorter in the later sessions, focusing only on the difficult parts. The goal in this is correct production of the components before moving on to the practice, because in practice there's no cues given. And we collect data on correctly produced non-words and concepts so we know what to practice in the following sessions. In the practice phase, in each practice there's 5 blocks of drill imitations with 20 non-words in each. So there's 100 repetitions per session, and it goes the same words in every session and in every block. And the child imitates the therapist's production. We give feedback only on correct or incorrect and only on about 50% of the productions to teach the child to self-evaluate. And feedback is delayed about 3 to 5 seconds. To be correct, all 3 components of the word need to be simultaneously correct. And between each block there's a 2-minute break where you can do any activity that the child wants to do without focusing on the speech. And the words are chosen depending on the client. For the sounds, it's the accuracy of the phoneme production, taught through different cues such as articulation or resonance, as nasal or non-nasal. And then the beats is the stress pattern, the rhythm of stressed or unstressed syllables, including length, loudness, and pitch. For this we can use metaphors, visual support, modeling, and demonstration to teach in the training phase. Often it's taught using long versus short and different visual aids. And the last component, the smoothness, is fluent speech, so syllables shouldn't be separated incorrectly, and there should be no hesitations or restarts or breaks. We can use pictures, metaphors, modeling, demonstration. For example, different chains to connect the parts of the word together, or trains or other things. To evaluate the progress within the intervention, we can collect data on correctly produced words and concepts, so we can see if the child makes progress. Since the words are the same in every session, we can see improvement between sessions through this way, and it is considered motor learning. McCabe et al. Also suggests making a chart of treated and untreated words and filling it in for every session to be able to easily follow this up to see if they're becoming more accurate, the productions. And this is also a way to show the family and the child the progress. Then we can also test real words before and after treatment, and for example 4 months post-treatment. These are not worked on in the program, so improvement on these implicates generalization. And this is what we aim to get with REST. And the non-words don't have an effect on everyday life or speech intelligibility, so by collecting data on the generalizations, we can see if the treatment is transferring to real words and phrases. And we can try to find words similar in structure to the treated words, so we can test the generalization better, as the generalization tends to happen on the same or lower level complexity. McCabe et al. Also suggests using an intelligibility scale to determine if there are improvements in how well the child is being understood by others, better generalization to real-life situation, and impact on daily life. For example, you can use the intelligibility in context scale. I presented the REST intervention, and now I'm going to talk about the intervention for Amelia, so for our client. And this treatment is suitable as an intervention for her as it's the appropriate age, and her profile of childhood hyperactive speech matches. So she's got inconsistent speech errors, prosodic difficulties, difficulty with multisyllabic words, but she can produce simple words and attempt imitation of multisyllabic sequences, and she's suitable for high intensity structured therapy. as well as that it's also, of course, proven to be efficient. The intervention will be delivered face-to-face with a speech therapist, and the non-words will be presented in a random order on cards on paper for her. Between the practice blocks, Emilia can choose preferred games to have as breaks, so it's for motivation and to support engagement. The sessions will last 1 hour, and the frequency will be 4 times a week for 3 weeks, which is a frequency that's been proven to be efficient. We use a chart to track correct and incorrect words and concepts to help monitor progress across the sessions within the intervention. And in the rest, there's no practicing at home. All the practice is done in the sessions, so we can make sure it's performed correctly. For the intervention, we can use different words depending on the client. And you can, for example, use 2 or 3 syllable words. And once these are produced correctly, you can move on to longer words in the next intervention block. For Emilia, we chose 3 syllable words. So you can see them here down on the left of the screen. And when you choose the nonsense words, you choose 4 vowel sounds and 4 consonant sounds. And this set of words that we chose is an existing set by the University of Sydney. And in this set, 10 of the words will take the lexical stress pattern of strong, weak, weak, and 10 of them will be weak, strong, weak. But you can also choose to make a new set of words or modify existing ones. In the next clip, we're going to do a role play where I'm going to be the therapist and Finn is going to be the client to show how a part of the training phase looks and then a part of the practice phase, not a whole session, just a few words to show how it can look. Okay, today we're going to play a silly word game. Some parts of the words are strong and some are weak. Okay, this is the first word and you just listen to me. It's Sabiner. Okay, here you heard the strong part, it's the B in the middle. Let's try it together, you can tap with me. Sabiner. Nice, that was good. Now listen to this one. This one's Butcher. And the first part is the strong part. Okay?
Butcher.
Almost. Listen again. The first part's the strong. Butcher.
Butcher.
Nice. That was, you got it. Let's try another one. This one's Goibichi.
Goibichi.
Let's break it down a little bit. So it's Goibichi.
Goibichi.
Yes, nice. And now we try to say it smoothly, all in one. Goibichi.
Goibichi.
Good job. Now we're going to go on to play a faster game, okay? Here's the first word. It's Suchber.
Suchber.
Not quite. We try the next one. This one's Boigersi.
Boigersi.
That was right. Well done. Now this one's Sabiner.
Sabiner.
Was that right or wrong?
Right.
Yes, well done with your listening. Very good. Now we do this one. It's Seguni.
Seguni.
Not quite. We try one more, okay? Last one for today. Butcher.
Butcher.
Good job. That was very well done. You did very well on the strong and the weak parts of the words.
So to conclude, child apraxia of speech is a motor speech disorder that affects the planning and coordination of the movements needed for speech. Early intervention is important because speech difficulties can negatively impact communication, learning, and social participation. Research shows that intensive speech therapy with repetitive motor practice can improve speech accuracy and intelligibility, and treatment usually involves individualized speech therapy using visual support, repetition, and frequent motor practice, which, for example, would be rest.